Okay, every week I think I say we're going to do this every other week, and something that is somewhat pivotal comes up, and we talk about COVID again. Imagine that. So today is going to be a little bit different because I know Paul and Dr. Cook and I have both talked about we got to push this disease to the outpatient world. And that was just for us trying to get ahead of it. And the change that we have today, one of the two changes we'll focus on, is that we got tools on board to do something with that now. A lot of them have been delayed. Seems like every week we say, oh, it's going to be here today and it's tomorrow kind of deal. But they're here and more coming. So we decided we would do a little bit. A couple of things about this. We are going to post this as enduring materials on the AHEC website. I've created a little one-page outpatient management of COVID thing. I know the vast majority of you have no need for that. But I think it may help some other people. And so that will be posted hopefully before I finish in the chat room. We'll go over it. And we know there's going to be some changes in the coming weeks as vaccines come out and all that kind of stuff. And so change this little document probably once every 2 to 4 weeks. And so we'll refresh that for you. But I think you'll understand why we decided to put that up as we go forward today. All right, so I think everybody knows we blew way past 500,000 cases on planet Earth per day. This was several days ago. We busted through 600,000 a couple of days ago, and we almost got back there yesterday. So a lot going on in a lot of countries. This is the U.S. data, and we blew up to 142,000 yesterday. And a lot of people said, well, the election, it wasn't going to bother anybody. This is election day right here. So maybe not. And this is daily deaths. And we've talked many times about, if you look at cases, low, bigger, higher, deaths, higher, lower, lower. And that's raw counts. If you do case fatality rate, the slope on the decrease in death rate is really quite remarkable in some places. And we'll come back to that in a moment. It's North Carolina, and we busted through 3,000 cases yesterday, first time ever. So we're sort of in a bind, and as you know, the governor made some adjustments to the stage phase, whatever they call it, 3 we're in, of moving from 25 people together to 10 people together. If you go to the DHS website, there's about 35 exceptions to that. So if you're administratively responsible for something, I would encourage you to, it's the 7-day average new cases, and we popped through 3,000 just yesterday. Deaths, and we talked about this in North Carolina. And we were talking about tests and 1,200 hospitalized. Our testing percent positive is creeping up a little bit. And the yellow line, which you can't really see, sorry, is us. We're still down below 200. But what you see is the Forsyth County triad area is starting to take off, and I'll show you some more data on that. They're really the major growth area. This is Forsyth County's data. We have our chair call this afternoon at 4. I haven't talked to them in a couple of weeks, but in the past couple of weeks, they've really flipped over here. And it's sort of interesting, I've always brought up in there, is there just a certain number of people that's going to get this? And Wake has always had it a little easier than some of the other major hospital systems. And so maybe it's their trying. When I say Wake, I mean Wake Forest, Winston-Salem, not Wake Med, by the way. So that part of the states really are hurting. Wake County, decline, Alan. Wake had sort of been pretty good. This is raw count, folks. You need to keep understanding this. And Wake County is a pretty big place, but they're starting to have some serious numbers, as you can see yesterday, up at right around 300 new cases. Now I've lost my mouse thing again. Great. Huh? I'm going to click where it's supposed to be. Nothing happened. All right. So go down. It's back. It's back. I see it. All right. This is an interesting one. Dare County, they shut down the border when all this stuff started. That's why they call it the state of dare. But that doesn't seem to be working so well. They reported 77 cases in one day. I don't see that on this bar here. I'm sorry, 77 cases last week. Sorry, I misspoke. But if you look at the again, it's where you actually live. That's a lot of cases for Dare County. All right, just a couple of chip shot things before we get into the outpatient management. I think y'all heard this. It came out in Science last week. Basically, what they demonstrated is a lot of people already have antibodies. We talked about this when it first got started. As many of you know, that a big chunk of the quote unquote cold season are coronaviruses, and the early antibody tests, there was cross-reactivity. Well, they've actually documented SARS-CoV-2 antibodies. They seem to predominate in younger populations. And there's quite a few people, at least in the population they assessed, that have these. And what really surprised me more, and I guess I forgot to put that slide in here, sorry, is they are very robust neutralizing antibodies. These are not just antibodies to something on the molecule. This is, they're actually neutralizing. So may explain some of the things we're seeing. And the titer of the neutralizing antibody was also remarkable. Most of them were against a different area that most of our therapeutic areas have gone after. A little interesting, but again, they were neutralizing by assay. There's probably a dozen of these models, mathematical models, where you put age and all that kind of stuff in and try to figure out who's going to do well and who's not. And I think we all by this time have seen folks that we thought would do poorly do well, and vice versa. And they've come up with this data. It came out in Cell a couple of days ago, where they looked at CRP. And basically, the short of the message is this: if at 48 hours you haven't crossed 100 on your CRP, you're probably going to be okay. And I'll come back to that when we get into some of the guidelines. We can't be drawing blood on everybody every day, but in some people, maybe we should. And this got a lot of traction in the news. This is in the New York Times yesterday, and this is the paper associated with it. I will tell you right now, I got way big concerns about it. And this is what I call one of these cell phone papers. This is one of the later ones. A couple of things with it is it's very old data. This is from back in March to May. Number one. Number two, these are done in central city, major metropolitan areas, Chicago, Atlanta, Houston, etc. So I think it does help us a little bit. But I also recognize that this is a very different time during this pandemic. And basically what they came up with is this, is restaurant, in-house eating in a restaurant is probably a way bad idea. Being in a gym is probably a way bad idea. And so as the governor has slowed us down a little bit, and as we get into these holidays, I've always said that the problem, and we've seen this in break rooms in the hospital, by the way, the problem with eating is you have to take your mask off. And the problem with eating with other people is you tend to talk while you're trying to eat. And that is just a great model for trying to spread oral pathogens or respiratory pathogens. So even though I have concerns about the mechanisms of this, anybody's ever driven on I-95 and tried to see if your cell phone could tell you there's a problem, know how crazy that can be. But I think it does tell us a couple of things that's going to be very pertinent as we move into the holiday season. All right, so this is a document that Paul Cook and I created. I'm going to drag Paul down with me on this, even though I probably created a fair amount of it. And I know that most of you watching this do not need this, but last week after our talk, we got pinged a fair amount by some of you. I'm sure you're still on the line this week that, man, we're seeing some really weird stuff going on out there. And we're seeing people that come in with a cough and they get sent for a COVID test and they get a Z-Pack and a steroid dose pack. And of course, 2 days later, their COVID test comes back positive, and then they go see somebody else. And they're like, well, what do I do? I'm not going to tell you what to do with a patient I can't see. But I tell you, and Paul, I'm going to look at you as I say this, if you've got a high index of suspicion of COVID, the recovery trial demonstrated that patients that were not requiring oxygen actually did worse with steroids. And azithromycin does interesting things, not as much so as other drugs in that class, to your conduction issues in your heart. And that's not a really nice thing to do to people. And so since Paul's the antibiotic stewardship guy, I would really encourage you to, where possible, to avoid empiric therapy until you have your test back, especially if you're going to choose those two agents. This also can serve a little bit for helping patients. There's some links and stuff in here. And now that I look at it, I see I have the old version of this. So that's great, because I'm going to beg you to beat this up and email me and say, you idiot, you shouldn't put that in there, because I want this to be our document, not mine and Paul's document. I put a couple of things in here that we get inundated with, but I stole the one from Japan because I think it adds to the 3 W's, and that's the 3 C's. Don't do closed areas, don't do crowded areas, and don't get close to people. I think that really rounds out a lot of the 3 W's that we get all day long. Get a flu shot. Enough said. All right, so we talked about vitamin D. And by the way, as I look at this, as we got to it, I realized the old version is up. So the new version will be posted on that link that's going to come to you for those of you that want it. I think exercise is important, probably more important for your head than for everything else. But do it in a safe environment. I'm not so sure a gym is the best place to be doing that. And I think as wigged out as everybody is, getting out and getting around a tree is a good thing. Not today with the rain, but when it's better. If you're overweight, try to lose some. That is probably the major risk factor. If you're diabetic, consider agents with potential to reduce severe COVID risk. We've talked about this many times. It's not for the faint of heart. I've got some folks, the new edition will have the reference to the Diabetes Care article. I'm sorry, again, this is the old version. But I think if you've got somebody and they're overweight and they're on a ton of insulin, and you can make it happen with some of these newer agents, they're very expensive. If they can do metformin, that's great. Try to put them on an agent that will actually, potentially, there's no randomized controlled prospective trials, but from an observational standpoint, many of these trials have been associated with reduced risk, so with these new agents. If you're hypertensive and have an indication to be on an ACE or an ARB, you need to be on it. And so that's just everyday stuff. So what do you do if you had a COVID test and you're waiting for results? Well, as I talked about before, a lot of things going on in this space. I think, and we do this at our house. I don't own stock in Zicam, but some form of zinc. Zicam actually tastes good. That's why I bought that one. And it's probably no risk, and it's not that expensive. Melatonin, Pepcid, and all the other things that Donald Trump got. I mean, if you're on melatonin and you do well with it, I think that's great. Or if you've got reflux, you take Pepcid every now and then, that's great. I'm not so sure it's a good idea to start those agents independent of an indication. And happy to hear any pushback on that. Obviously, if you're waiting for results and you're high risk, you need self-quarantine. And I put the CDC link down here. And, you know, a lot of people have talked about you go get your COVID test and you're waiting and they tell you to go to CDC. And it's a big document. There's a lot of stuff there. I think most people on this call can digest all of that. I would ask you to think about, I'm not so sure your patients can, because that's a lot of data there. But I think we need to have that as a sort of a standard, is what our country has done. So now, if you get called up and you're positive, well, you need to continue self-quarantine, and I'm sure there'll be pushback on 10 days, but that's sort of what I believe in. The next number, and I'm not going to bore down on this, going to let Paul talk about it, is the number to call to try to get some folks into clinical trials as an outpatient specifically. And again, I'm going to leave that up to Paul. There's some really cool stuff happening in that space, and even more cool stuff coming down the road. If you get short of breath, you need to go see somebody. I know we're trying to keep people away from the healthcare mechanism, but if you're short of breath, you need to see somebody. If you've got a real high-risk patient that you're worried about, seeing them or getting them to get a blood draw around 48 hours, if their CRP is above 100, you might want to think that that's a risk factor in of itself. If it's less, that could be reassuring. And the last thing I think will be a good transition into Paul Cook's talk. The timing of therapy is critical. And we've seen this over and over and over again in trials. The only thing we have right now that we're sure of that works in late stage disease is steroids. We have another agent that's showing promise. All the other therapies, convalescent plasma, monoclonals, antivirals, work best in patients in early disease. And even though you'll see some people say before 7 days, before 10 days, before 3 days, if you had to pick a number on me, the shorter one. I know those of you that struggle with, when to put somebody on a trial versus they're going to get better on their own. I know how hard that is. But I also know that if you wait too long, that's a horse you're not going to catch. So this will be posted, and as I said, we will change it as the vaccine comes out, as monoclonals become more prevalent, that Paul, I'm sure we'll talk about in a moment. But we're going to post this. You'll get an email link to this. I would encourage any of you that have troubles with any of this to push that out to me or Paul, and we'll kick it around and see, because I really want this to be your document. Yes, ma'am.
The link is in the chat right now.
Okay. Right. So the link's in your chat, but again, this is the old document, and I'll upload the new one when I get back over to the shop. And that's my last slide. And Paul, I'm going to turn it over to you.
Okay, we're okay. Hear me all right, I guess? All right, so one of the reasons I like for Dr. Boland to go first is usually there's problems at the beginning, and by the time I get up here, there's no more problems. So we'll hope that holds true today. So what I'm going to talk about is a few things. Bamlanivimab is one of them, and yep, that's the name, and I don't know how they came up with that name, but we'll talk about that in a minute. So the clinical trials, I am going to briefly mention in this slide, and probably not so much anymore. The trial that we have now is not what the emergency use authorization is. It's a double monoclonal antibody. So I left this off. It's Bamlanivimab plus another monoclonal, and that one is named, I had to write it down, LYCOV016. So it's actually two monoclonal antibodies, similar to what President Trump received, except he got the Regeneron version of this. This is the Lilly version with the clinical trial. And that trial will continue. It's actually fairly close to being complete as far as enrolling the number of folks in the trial. So otherwise, we're almost ready to start this remdesivir trial. The reason this has been postponed now actually, believe it or not, has nothing to do with ECU, has to do with Gilead, the company. They had a change in the protocol, and they put the trial on hold, they say for a very short period of time. And so we're hoping that this would open up maybe next week, but we'll see. Baricitinib is this drug that is actually a Lilly drug as well. It's used and FDA approved for rheumatoid arthritis. And as I've mentioned previously, this drug appears to be somewhat effective as compared to standard of care therapy. So shortening hospitalizations, et cetera, but we'll see. And we actually will be ready to enroll patients in that study tomorrow. Okay, so stay tuned. And if you have patients, if the hospitals have patients now that they think are not doing so well with standard of care and they've been in a short period of time or they got admitted today, let me know, because I think tomorrow we will be ready to enroll patients in that study. This drug is an oral drug. As I said, it's already FDA approved for something else. That's rheumatoid arthritis. So we know quite a bit about it. And this would be a randomized double-blind trial compared to standard of care. Now, this last study, MK4482, this actually has a name too that I don't remember. It begins with an M. Basically, this is in hospitalized patients, but with early disease. This is an oral antiviral, a cytidine analog. I talked about this last week. I'm not going to talk about it much more. We're not quite ready to start with this one, but we're getting close. We did get IRB approval for this just yesterday, and I think either next week or the week after that. And what we're trying to do with this one is to identify persons who are early illness. I mean, if they come in and they need to be put on a ventilator, they are not candidates for this study. Absolutely not. But if they've got mild disease and we are sort of on the fence about whether they should be admitted or not, we are sort of leaning towards perhaps admitting these patients, getting them started on the drug, and then if they're better and can go home, they can actually go home with the drug. So unlike baricitinib, if the patients improve with that, the drug stops in the hospital. But with the MK4482, they can be in the hospital as little as 1 day and finish the 5-day course of therapy as an outpatient. Okay, so as Dr. Boland mentioned, the viral phase is early on, and I can't tell you how many requests for remdesivir I've rejected in the last week, but it's a lot. And basically what I'm saying is these people are too far into their illness, whether on the history, they've been sick for a week or more, or I look at their CRP and it's 250 and they have horrible infiltrates on their chest x-ray or CT scan. That's a dexamethasone patient. That's not a remdesivir patient. And I'll leave it at that. But otherwise, the MK4482 is in the viral response phase. The EUA, which I'm talking about in just a minute, is in the viral response phase. The remdesivir as an outpatient is in the viral response phase. These are all in the stage 1 or early infection period. So this is the study, and I'll just show a couple of graphs from this study. It appeared just recently in the New England Journal. And the drug LYCOV555 is the same drug that we're going to talk about that is hard to pronounce. So this is, I think, some interesting data, and I think this is basically the crux of the study. Is they did a dose response, 700 milligrams, 2,800 milligrams, 7,000 milligrams, and so patients got randomized to receive either of those doses versus placebo. And what you can see is that they looked at then follow these patients and who got hospitalized, and basically. There was no dose response here. In other words, 700 milligrams worked just as well as 7,000 milligrams, which is good to know because what they ended up with is 700 milligrams. And of course, that is 10 doses as compared to 7,000 milligrams. So it allows them to produce more of the drug or to have more persons who are available to get the drug. And so if you got any of these doses, 5 of those 309 patients who got that ended up in the hospital versus 9 of the 143 who got placebo. And this is randomized double blind. I did the p-value on this myself. It's pretty easy to do. Fisher's exact test, 0.015. I got my decimal point in the right place this time. Okay, so that is statistically significant. And basically what happened is Lilly settled on 700 milligrams. And so here we go. And this, I don't want to bore you with this. What I will point out is that side effects, very uncommon. We haven't seen anybody have any infusion-related side effects to this, which is not surprising because monoclonal antibodies are usually very safe and similar to placebo. So you see at the top it says any side effects. 24% got side effects. Well, look at that. 24% who got placebo got side effects too. So basically same as placebo as far as side effects are concerned. So I copied this from the Lilly site. They have they have this description on how to pronounce the darn word, Bamlanivimab, okay? And it has a website, okay? Bamlanivimab. Probably has a Twitter, we don't know that yet. But how they came up with this name, I have no idea. Now, just as an aside, the new drug that they have, which is 2 monoclonal antibodies. So I'm guessing what they're going to name this, and I've got 2 guesses. One is it's 2, so you have maybe Bam Bam Mab, okay, like Flintstones. So it'd be Bam Bam Mab, or you could have a palindrome where you have Bam Bam Mab, and so frontwards or backwards, it's the same. Now, I don't know who gets paid to name these things, but that's what I'm throwing my hat in the ring and saying for the next one. We'll see. Okay, so back to reality. The emergency use authorization, the hospital will be receiving, I'm told, about 100 doses of this drug, Bamlanivimab, and they will be dispensing this to the regional hospitals for administration to patients. So I copied this directly from the information that we got, but you can see that this is, so this is not an FDA approval. It's an emergency use authorization. This is what remdesivir went through before it became FDA approved. And here's the deal as far as the age, the weight, at least 40 kilograms. Of course, that's mainly for children, and at high risk for progressing. So if somebody's in the hospital, they're not candidates, period. Okay, I don't have a slide for that, but if they're in the hospital, they're not candidates for this. If you have any of these risk factors, BMI greater than 35, CKD, diabetes, immunosuppressive disease, age over 65, you're a candidate for the drug. Okay, does that mean you're going to get the drug? Not necessarily, because remember, we've got 100 doses for the region, and Dr. Boland showed the number of cases that we have. So I'm not sure that you would necessarily get the drug, even if you met the criteria, but you probably would. But we'll find out how this is going to work. So here's some more sort of nuts and bolts of this, which I think is probably worth considering since we're going to have places that are going to do this. And it's not just going to be in Greenville, by the way. This is going to be in the regional hospitals as well, because it makes no sense to have folks from Duplin County or Ahoskie coming to Greenville to get this this drug. So this is, as I mentioned, the 700 milligram dose. It's in 20 milliliter vial. So what happens is you take a 250 mil normal saline bag, you take 70 milliliters out, and you put 20 mLs of this in, which is 700 milligrams, and what you got is 200 mils, okay? And you give that over an hour, and so that's it. And we don't expect to see infusion-related reactions, and then you watch the person for an hour afterwards, get some vital signs, and you're good to go. Okay, so what happens to the clinical trial? It continues. It's about over. The clinical trial involves 2 monoclonal antibodies, as I mentioned, and so I think we're likely to get good information from this. Well, we'll get some information. What we suspect is that this would reduce the risk of hospitalization. And given that it has 2 monoclonal antibodies, we think it may be more effective, or we think it might be effective in case there's a mutation in the virus. Okay, so I think this is my last slide, and then we can maybe answer some questions. But the bottom line, and we've shown this slide previously, and I stole this slide from some presentation, but where we're targeting and where we're going is early in the course of the infection. Here, when persons are on the inflammatory in the ICU on ventilators, the cytokine storm, this is way past remdesivir. This is way past Bamlanivimab. Oh boy, you know, the Lilly drug. It's way past the MK-4482. Okay, so we're trying to get people that are over here that are early in the course of the illness. As Dr. Boland said, 7 days, 5 days, 3 days. The earlier, the better. And we want to have EDs or primary care doctors send us or refer us patients who are high risk to see if they may be eligible for any of these trials. All right, we're done. Boy, okay. Anything I say, so I'm going to plead the fifth on this one. I'm going to have to look this one up and get back to you, Dr. Boland. I'd have to see what they define as CKD as far as the GFR. I'm not quite sure. Frequently, these things are like less than or equal to 40 or 30, but I'll get back to you on that.
And let me tell everybody that why that's important. You know, let's pretend that despite all the hubbub about it, we can still use the MDRD4 equation to auto-calculate it for us. You know, there are definitions of CKD as high as 90 cc per minute. I don't subscribe to that. I'm a 60 kind of guy. But
you don't think they want you up here?
Sorry. So I think when we do these, Paul, you're still going to have these restricted ID, right?
Right.
So I don't think you guys are going to have to struggle with it, but I just would remind people, and I don't see a nephrologist on this first set of names up here, but I bet there's one, so you can call me out on this. But despite all the hubbub about the MDRD equation, you know, we still auto-calculate the MDRD4. And there are some definitions that claim stage 2 CKD is a real thing, and that goes up to 90 or 89 cc's. I'm not so sure I believe in that. I think the trouble is this: we've always had that classification, but we've never had any guidelines on what to do above 60 cc's. So isn't there a call today with Merck at 4? We should ask them. And so we'll get calls from folks before they use this drug. So we'll have an answer for you. I guess what I would encourage you to say or to do, and this is why we created the MDRD4 equation, is there's a lot of people out there with what looks like a pretty normal creatinine, their GFR is in a tank. And so I would really encourage you, as you're seeing these COVID patients, to look at that. So Nicole, you are great, and I'm going to talk to our folks about posting the inpatient, because you do reference those trials, and not to overwhelm everybody with data, but I think that's a marvelous idea. And just so you know, Nicole, if you're listening, this will be going out to a lot of people. I think Mildred told me the circulation for this is like 23,000 emails or something. This is a good point about, I will talk to our folks about that and circulate that through Jason, and there's some folks on here, get them through their clinics. That is a really good point. As we know now, there are some chronic shedders, whether that matters or not, we actually don't know, but I think that's a really good point. And again, as I was getting ready to say, when this document gets posted, you get a link to it. I really, really want your pushback. because I want this to be an effective document for everybody. I'm really putting together more to be beat up than I did for it to be definitive. And we'll probably update it every 2 to 4 weeks. Some people believe we may have a vaccine in 3 weeks. And as this Bamlanivimab becomes more available, they claim they will have, I think I heard, Paul, 1 million doses by the end of the calendar year. So that's a ramp up of 700,000 in a month and a half. So do the math on that. So we'll see. Distribution plans on the vaccine. That gets to be interesting, and somebody can correct me on this. As I understand it, Pfizer did not take CARES Act money, which means that they do not have to go through the McKesson plan for distribution. And what I have read on their website is that they're going to go through individual states. So I'm sure it will come from above, as they say. We've got some really cool work going on here. Some of our colleagues have actually created a plan, and the last I heard on that is DHHS is looking at that. So we actually may end up having a big say in how it comes out. Obviously, there is going to be a push for healthcare workers to get theirs first. Is there a definition of immunosuppressive drug? Wow. Wow. Well, I think you know the big one. I think what the part of your sentence is the big one. I'll tell you an example from my life in transplant. We know that once you get down to 5 milligrams of prednisone per day, basically most of the potential big problems are mitigated. Now, there's a couple that stick around, cataracts and bone disease being 2 of them. But at that dose, a lot of the bigger ones are not there. I can't tell you what that does for T-cell responses off the top of my head, and I'm sure there's somebody on the call smarter than me who could type that in. But I will also tell you, if you've been on 5 milligrams of prednisone for a long time, you're immunosuppressed, in my humble opinion. And if nothing else, you have an abnormal axis. So I would say all the drugs we know, cyclosporin, Prograf, and all those NABs that are out there that none of us can pronounce, yeah, any immunosuppressive drug does put you at risk.
I'll just make a comment about the prednisone dose. Having done a lot of trials, typically what is used is 20 milligrams or more of prednisone. Yeah.
To classify that as excluded.
Exactly. Yeah. But how they pick that, I don't know, but it's somewhat arbitrary.
And I don't know if the question was going after a trial or, classifying somebody on your own plans as far as are they at high risk or not. I'm not going to differ with what Paul said, but again, if somebody's been on prednisone for 5 milligrams and obviously every now and then on more, I would argue they're at high risk for bad outcomes. And that's how I was answering it. So thank you, Paul, for clarifying it. That may not be enough if that's their sole risk factor to get them on your trial, if it has to be 20. But again, you're going to have to call to get these drugs. So we all carry these little cards around so we know what to do. So, all right, I'll see y'all next week. Again, this is going to be posted and we'll go from there. Thank y'all. See you later.